My background is I'm a doctor, trained as a medical physician up to registrar level. Worked for the British Medical Journal for a few years, essentially translating research into clinical practice, and co-founded See the Signs with B about 8 years ago now. And my talk really is about cancer in numbers, as it says, but why interception really does matter. And I'm going to be talking to you about statistics in the general sense. Obviously, we've just heard Chris Hoy's story. It's an unusual case. And unfortunately, the statistics that I'm going to talk to you about, he's in the minority. But there's a big opportunity as well that we can all achieve. So there'll be statistics that most of you will be familiar with, and hopefully there'll be things that are new to you, and what See the Signs is doing and what research we've got so far that shows that we're helping. So 1 in 2 people will develop cancer at some point in their lifetime in the UK. And stage of diagnosis is the most important factor in survival. So if you're diagnosed early, so in stages 1 or 2, chance of survival at 5 years is now 90%. At 10 years, it's 80%. Studies don't really go beyond 10 years, so that's really curative. But if you're diagnosed late stage, with the best treatments in the world, it's 30%. And some cancers are much, much worse than that. So you take pancreatic cancer, it's less than 5%. So if we can catch them early, we can make a massive difference. So in terms of cancer in the UK, cancer is changing. So cancer is increasing in the younger population. So now 40% of patients that are under 65, 40% of cancer is diagnosed in that age group. It's the biggest contributor to premature death in that age group. The fastest moving age group is the 25 to 49-year-olds. They've increased over the last 25 years by 24%. If you compare that to the fastest growing age category, which is the over 75s, they've grown by about 10%. So it's really shifting in the younger population. At the moment in the UK, according to the Darcy report, we achieve early stage diagnosis in 58% of the population. So we've still got a way to go to the NHS former long-term plan, which is obviously has just been updated. The cancer plan's coming later this year, but the target was 75% by 2028. So we're still way off that target. There's also a financial incentive for early stage detection. For every single case that we diagnose early, you save about £6,000. So if we talk about the marginal gains that Chris Hoy was talking about, for every 0.1% we change, it's about £2 million that the NHS saves just in catching those patients early. But one big statistic that is really important to recognise is that 95% of patients have symptoms at the point of diagnosis. I say that because some historic websites, they've actually changed it now, but on things like the American Cancer Society, they used to say that early diagnosis doesn't have symptoms. And it's simply not true. If 58% are diagnosed early and 95% present with symptoms, patients have symptoms in the early stages. We've just got to identify them, and that's the challenge. So I like to show this graph. It's from NHS Improvement. It's slightly old now, so the statistics have slightly changed, and obviously it references 2-week wait, which was the old cancer referrals. They're now called urgent suspected cancer referrals. But it essentially shows the place where you're diagnosed with symptomatic cancer really does matter as well. So this essentially plots 12-month survival on the left-hand side, on the y-axis, and on the x-axis is the proportion of patients. Don't worry too much. But in the very top right-hand corner, that green dot with the red circle around it, that's your urgent suspected cancer referrals. So if you're referred by a GP for cancer referrals, you've got the best chance of survival. All the other spots across the top are various places in secondary care. The red dot at the bottom, which has a 40% survival at 1 year, is emergency room, A&E diagnosis. If you're diagnosed in the emergency room, it's late stage, it tends to be late stage, and your chance of survival falls through the floor. But it's really challenging. And I want to take you through how patients evolve through their symptoms and how we try to respond to that. So in early diagnosis, the first stage is patients don't have symptoms. And that's why we operate screening. And so at the moment, we only screen for 4 cancers with screening programs, 5 if you count the optional PSA test that we were mentioning before. 95% of them are diagnosed early. We've still got a long way to go. Unfortunately, screening rates are declining. But if you look at other countries like the US diagnoses about 14% of all their cancers through screening programs. So we're actually quite a way off what we could be doing with screening at the moment. And that's partly due to their intervals are shorter, partly due to cutoffs, so like for FIT testing, which is for bowel screening, but also the amount of patients that actually go through screening is higher in the US than the UK. The next stage is when patients start developing symptoms. And it's at this stage that the patient needs to overcome a threshold. When are they actually going to see their GP? And there are many reasons for why patients don't initially respond to their initial symptoms. These are sort of some of the most common ones. So interference with life, so as soon as they can't go to work or it's affecting their social life. There's this complex term, temporalizing symptom duration. That basically means that they set themselves up for like a goal. So if this symptom hasn't gone in a week, I'll go and see the doctor, or 2 weeks, or whatever. Interpersonal crisis, which tends to affect sort of mental health side of things. Sanctioning, so has someone told them that they should go and see the doctor, whether that's a relative, a family member, a friend, or it could be sort of on TV, it could be an advertisement that they see. And then the symptoms becoming intolerable, which tends to be around sort of pain-related symptoms. Then they go and see the GP, and this is a real challenge for the GP practices and the multidisciplinary teams that operate to identify these patients early. And that's because cancer is not one disease, it's 200 fairly different diseases that all can present in virtually every conceivable way as every other condition that's going. They can present with virtually every symptom that's going. And it can present at any age, any gender, any ethnicity. And you've got 7 minutes to work out whether this patient could be at risk. It's a challenge, a big challenge. And that's why 45% of patients are missed on their first appointment. So you go and see your doctor with potentially cancer symptoms, 45% of patients will be missed, on average, on their first appointment. 20% of patients will see their GP 3 times or more before being suspected of having cancer. And it's actually much worse in ethnic minority populations as well. And that's, to some degree, when you base guidelines on a mostly white population, it does create outliers that's more challenging to operate in. Then they attend secondary care with their urgent suspected cancer referral. It used to be 2-week wait, so it used to have to be within a 2-week period. And there's now a target that came in last year, or just before, maybe 2 years ago, which was the first appointment, by the time the patient is diagnosed with cancer, needs to be within 28 days, or they need to have cancer excluded. Currently, we are just above the target, 76%. This was from April, which is the most recent data. But that statistic of 75% as the target was supposed to go up to 80% at the beginning of this year. It's now going up in March 26 because we're not meeting it. So we'll move it up when we're meeting it, I think is the mantra at the moment. But the 62-day target, we're only reaching 71%, and that should be 85%. So we're way under. We were doing much better before COVID, and now it's been declining since COVID because of the elective recovery, because more patients are being diagnosed with cancer, more treatments, etc. And then the final place, as we said, was A&E. And being diagnosed in A&E, as I said, your chance of survival at 1 year is 40%. But really importantly, when audits have been done of these patients, over 2/3 of them have been seen in primary care with accelerating symptoms in the previous 12 months. So it gives a real opportunity for all these earlier stages to identify that patient at an earlier place. And the reason why I did this in a timeline fashion, because this can take years. It can take 2, 3 years, up to 5 years to go from that side of the board to the other side. But when it gets into sort of moving from the GP site into secondary care into A&E, your mortality rate rises very quickly. And this is on average between the most common cancers. But for every month that you wait, mortality will increase by 10%. So waiting longer than 28 days to diagnose someone, which has a knock-on effect to starting treatment, it's only when you start treatment does that start to go down, the mortality rate go down. So you have to try and make sure that every part of this, when Chris Hoy was talking about marginal gains, if we can make marginal gains in all these places, we can start to shift that needle and reduce that mortality rate. So how is See the Signs sort of approaching this? And our mission at See the Signs is to give everyone the chance to survive their cancer. And we do that now with three products, which is the point-of-care clinical decision support system that many people in the room will be using in their practice or are aware of. And that essentially allows you to risk assess patients in real time in the clinic, identify whether their symptoms could be cancer-related. It will tell you what cancer it may be, and it will also say what to do next that's based on your local referral guidance and national guidance from that side. And it will track those patients to make sure that they receive their referral, they receive their diagnosis or exclusion all the way through their journey. We now have, since last year, patient assessments. So that used to be called See My Signs for anyone familiar with it. And that gives patients now the options to risk assess themselves at home to overcome that threshold to come and see their GP. And we're soon to be releasing our case-finding module, which will allow you to find patients that are at risk or for options for screening, so patients that are not taking up things like cervical screening or for lung screening that we were talking about earlier. So where are these products sort of fitting in this line? So attends the GP practice. So remember, 20% of patients are seeing their GP 3 times or more. That's where a point of care decision support tool is operating right now. And there's some evidence coming out. I won't show you that because we don't have the sort of figures at the moment, but there's some evidence to show that we're capturing patients on the first appointment now, first and second appointment rather than the third or extension. Then we have patients' assessments, See My Signs, to capture that patient when they start having symptoms. So to overcome that threshold and get them into a care pathway straight away. And part of that is a provider dashboard, which is a component of the patient assessments, which tracks patients. It can track the patients back to primary care, so back to their GP, but it can also bypass them directly into secondary care pathways to get them on that pathway as soon as possible and to get that time down. And then finally, as I said, case finding is coming. That will allow you to find patients that have been missed potentially in primary care through test results that haven't necessarily been followed up or any symptoms that have been missed, capturing those patients that maybe have symptoms in the community or maybe need to be surveyed for their symptoms, and then asymptomatic patients, as I mentioned, around screening. So what has See the Signs shown in terms of evidence so far in the NHS? So with the point-of-care decision support system, we have shown in a very large study, this was in over 120,000 patients that were risk assessed, we showed that we had a 94% tumour accuracy. So where patients are being risk assessed, we can point in 94% of cases that what cancer they are at risk of and what to do next about it. We're increasing the number of patients that are being diagnosed in primary care by 8 to 12%. So remember the sort of statistic about finance before, about £6,000 for every case? You catch patients in primary care rather than later down the stage. You're catching them earlier. They have much better outcomes. There's really strong evidence that says primary care, the best place for them to be diagnosed. 8 to 12% increase. A 0.1% change in national levels would equate to about £2 million. So 8 to 12%, I can't even do the maths in it, but it gets to hundreds of millions. We've seen 20 to 50% improvements in time to diagnosis for patients. So getting them into those pathways as early as possible, not going on multiple referrals from that side. So far, we've had patients that have come through on 94. I'm sure that's probably changed now, and especially as the population ages as well, that will change. But our sensitivity for cancer is 99%. So when a patient has cancer, we will tell them that they're at risk of cancer 99% of the time. So it's less than 1% that we miss. And this conference was really structured around us achieving over 50,000 patients that were diagnosed. And this is sort of all the sort of breakdown that we've seen across our different areas where we operate. And this is largely in the breakdown of how cancers develop in the population. So just some of the evidence that sort of backs this up. So this is around cancer detection and how See the Signs was being used. This was in the east of England. And essentially, you're tracking back for 3-4 years of cancer detection rates in primary care, which is that statistic where if you catch it in primary care, it's much better outcomes for patients. It was tracking along with the red line is the control and the black line is NHS England. So all the lines were tracking virtually similarly. They introduced See the Signs. It jumped up by 12.3% in this case. Similarly, in patients with deprivation, so ethnic minority populations, poorer communities which tend to have poorer outcomes and later stage diagnosis, again, we saw tracking with its control sites in the same area, jumps up as soon as See the Signs is introduced. Over a longer period of time, we've got some members from this study here with us today, but we introduced See the Signs. It jumped up 12.9% over a couple of years, sustained above the controls in Greater Manchester and NHS England as well. We mentioned about the faster diagnostic standard and how that's not well achieved across the country at the moment, but this was in Somerset, and we showed that we improved the faster diagnostic standard for colorectal cancer by almost 50%. So really dramatically shifting, particularly with high-intensity pathways like colorectal, where there was a big workload related to it. And then just in terms of how the system works as well, is that you would always have a concern that if you're diagnosing more patients earlier, the old mantra was, it means that you're doing more activity. So you're creating more referrals, you're doing more diagnostics. And time again, we've shown, and this is just one study, that we're not doing that. And actually, we're using far less resources because we're identifying patients that are at risk and also excluding patients that aren't at risk. And we see about a 21% move away from urgent suspected cancer referrals, which are the most expensive type of referrals. And the conversion rate there was much higher than the NHS England one, which is the number of patients that turn out to have cancer as a result of those referrals. The key question next is, are we actually diagnosing cancer? early. And the challenge is that, for those of you familiar, is that staging data is not always tethered to the patient in primary care. It's usually in various different sources. So it took us a few years to be able to access some of the staging data. But this was in Somerset, where we looked at before using See the Signs and then after implementing See the Signs. And we looked at ovarian cancer here and dramatic changes in the early stage cancer here, over 53% improvement. Similarly, in the similar study, 133% in pancreatic cancer. Ovarian and pancreatic cancer, some of the worst performing cancers nationally, very low early stage detection across the country as well. And actually, we've got a new study that should be coming out later this year that looks at all cancers, certainly the top sort of 10, 15, and it shows that we are seeing stage shift on virtually every single cancer. Because the patient pathways, the patient assessments, See My Signs has been implemented for just over a year now, we don't have a huge amount of evidence behind it, but this was the first pathway that went live in Somerset for postmenopausal bleeding, to allow patients to risk assess themselves of whether they're at risk of endometrial cancer. And what was really interesting was we saw 600 patients risk assess themselves. They had a 5-day average time to review down from 60. So, a huge drop in time frames of when these patients would be delayed. The average time to diagnosis went from 48 days to 22 days. So that faster diagnostic standard, that's it was 75 at the moment, 80% shortly for diagnosing patients within 28 days. We're doing that now with this pathway. 35% also had a significant family history. So that case-finding system that I mentioned to you before, how can we identify those patients that are high risk, that may be suitable for genetic testing, that may be suitable for earlier interventions in the screening programs? How can we use those systems to supplement that? And the average age of completing this, because See the Signs, it's digital, the concern was, are people of age that are actually suffering with potential cancer symptoms using the system? The average age was 60, which is, broadly speaking, the average age of cancer. So that's just been like a whistle-stop tour through cancer in the NHS and how See the Signs is trying to operate that. And those systems that we have in place are all trying, as Chris Hoy was saying earlier, is to adopt a marginal gains approach to shift that needle earlier and earlier, and how we can use every single system here to drive that into earlier stage detection and survival for patients in the UK and beyond. Thank you.